effervescent enemy. So it's Mr. X, a 56-year-old gentleman from Katpadi, presented with an alleged history of ingestion of hydrogen peroxide. The time of incident was 6:30 p.m. on 29th of April, and the volume consumed was 40 ml of 50% hydrogen peroxide. So he was under the influence of ethanol at the time and mistakenly took it instead of alcohol. Within 20 minutes of ingestion, he developed severe burning pain in the throat, retrosternally, and the hoarseness of voice. So he was taken to the hospital as soon as possible. Gastric lavage was done in an outside hospital, following which he had one episode of vomiting and bloodstained sputum. Personal history: he has been a chronic ethanol consumer for the past 30 years with no known other comorbidities. Examination findings: pulse rate was 78, BPO 160 over 80, respiring at 24 per minute, saturating at 98% with GCS of 15 by 15. GRBS was 357 at the time of presentation. There was no pallor, icterus, cyanosis, clubbing, lipid edema, or lymphadenopathy. On local examination, throat showed ulceration over the hard palate and uvula was edematous. Tongue was normal. Systemic examination was unremarkable. So it's a case of corrosive poisoning and accidental ingestion of hydrogen peroxide. So the investigations done which showed a lactic acidosis in the ABG. ECG was normal sinus rhythm with left axis deviation and poor RV progression in V3 to V5 with T inversion in 1 and AVL. Hemoglobin was 15.5 with total counts of 21,500 with neutrophilic predominance with normal platelets. LFT was AST was elevated in LFT of 82. Electrolytes were within normal limits. Creatinine was also normal. There was no coagulopathy and urine routine showed glycosuria. Subsequent HB was 13.6 and AST/ALT was 20 and 13. On initial evaluation, the assessment of corrosive injury to esophagus, we have done an NPL scopy, which showed edematous ariepiglottic folds, congestive arytenoids, and congestive posterior pharyngeal wall. Bilateral focal cords were mobile and airway was mildly compromised. And the patient was cleared for upper GI scopy after steroids. So esophagus scopy showed a corrosive injury of Sargar grade 2B, circumferential erosions and superficial ulcers with spontaneous hemorrhage noted in the mid and lower esophagus. Stomach again showed a Sargar grade 2A injury with diffuse erythema with multiple blisters and erosions over the body and the antrum. 6 hours post admission, he developed a sudden onset weakness of his left upper limb and lower limb. And the neurologic examination at this time revealed power at the left upper limb was 3 by 5, left lower limb was 4 by 5, left-sided sensory extension, and we thought of an acute CV at this moment, and localization was towards the right parietal cortex. So the diagnosis here, we considered an acute cerebral. Because of sensory extensions. So when we check for fine touch on bilateral upper limbs, and if it's absent, when we check at the same time, if it's not pronounced on the left side or on one side, we can say that side is that side has sensory extension.
So you mean that there is loss of simultaneous perception?
Yes.
That is what you mean by sensory
Yes.
extension. I was not clear about that. Then your localization is correct. But primary modalities were preserved. But the primary modalities of sensation
yes.
preserved.
Yes.
You need to mention that also before you localize. Thanks.
So the diagnosis here was an acute cerebrovascular accident. Were there any risk factors of ASCVD? Yes, he is known his age, his ethanol consumer, his BP was elevated at presentation, and he is a diabetic, but newly diagnosed diabetic. We even thought of a diagnosis of holiday heart syndrome causing an atrial fibrillation, causing an embolic phenomenon. And the next thing what we thought was is a stroke related to the hydrogen peroxide poisoning per se. So the MRI, the diffusion restriction imaging showed acute infarcts in the bilateral high parietal regions, right high frontal region, left precentral gyrus, and left hemimedulla. The MRA was normal, and in view of multiple arterial territories, again a possibility of embolic phenomenon was considered. So 24-hour Holter at this time showed a sinus rhythm, no significant pauses or runs throughout, and echo showed a LVH trace MR grade 1 LV diastolic dysfunction, no clots or vegetation or pericardial effusion. And agitated saline contrast echo done, which was negative for extra or intracardiac shunts. So we considered this is a case, consider this as a case of cerebral air gas embolism secondary to hydrogen peroxide. And hydrogen peroxide is an oxidizing agent used in household disinfections, industrial cleaners, and hair bleaching products. Lower concentration of 3 to 6% is considered safe, whereas greater than 10% produces significant toxicity. Ingestion, particularly greater than 10%, can lead to severe complications, including corrosive mucosal injury, gastrointestinal perforations, aspiration pneumonitis, acute respiratory distress syndrome, cerebral air embolism, which is a rare phenomenon, and multi-organ dysfunction. So these are some case studies that we saw for the same. And as an 84-year-old man sustained a focal neurological deficit immediately after ingesting 30 ml of 30%, 35% hydrogen peroxide solution, and physical examination disclosed a left hemiparesis, frontal release signs, and cerebellar dysfunction. And MRI showed multiple cerebral and cerebellar infarctions in the anterior, middle, and posterior vascular territories. This is again another study which showed a 48-year-old male who took 2 sips of 33% hydrogen peroxide. A short time later, he developed hematemesis, left side hemiplegia, confusions, and left homonymous hemianopia. And MRI showed multiple infarcts in the vascular territories and ischemia likely due to the cerebral air gas embolism. And 18 hours into arrival, the patient was started on HBOT at 3 atmospheres for almost 30 minutes and 2.5 atmospheres for almost 60 minutes, following which he showed clinical improvement. And follow-up MRI at 6 months demonstrated resolution of hyperintensities. So the ingesting concentrated hydrogen peroxide leads to severe complications through 3 mechanisms. So corrosive mucosal injury, oxygen gas liberation, and oxidative stress from lipid peroxidation. So how can hydrogen peroxide cause a stroke? The hydrogen peroxide can cause serious harm due to its ability to diffuse through tissues and vasculature rapidly, and catalase enzymatically breaks it down to water and oxygen. And as oxygen release dependent on the concentration as well. And for example, 1 ml of 3% solution yields around 10 ml of oxygen, while 35% yields at around 100 ml. So this is another case where the patient was treated with hyperbaric oxygen, and this was the first case in 1998, after which the patient was successfully treated with to treat cerebral gas embolism caused by hydrogen peroxide. So the HBOT, it helps to reduce the size of air bubbles through nitrogen washout and improves oxygen delivery to ischemic tissues. So the outcomes after a high concentration peroxide ingestion, a 10-year study period of 41 out of 94 patients, 294 patients with symptoms after high concentration of hydrogen peroxide ingestion demonstrated evidence of embolic events, and 20 of the 294 patients. Sorry. So in our patient, the supplemental high concentration oxygen was given because of lack of availability of HBOT in our center. We gave 15 liters per minute of O2 via NRBM, and physiotherapy and occupational therapy were initiated early in the hospital stay. And for the corrosive mucosal injury, we started the patient on intravenous corticosteroids and adrenal nebulizations to address the upper airway edema. A gastroenterology consultation was obtained and a scopic NG tube was placed. IV fluids, thiamine, and analgesia were given. Nutritional supports was escalated from clear fluids to semi-solid diet via the NG tube, which was well tolerated. So the outcome, gradual neurological improvement was present after therapy of around 48 hours, with the lymph improving to at least 4+ out of 5, and he tolerated NG feeds without complications and remained hemodynamically stable. And he was discharged in a stable condition with advice to follow up under gastropharyngeal.
Air embolism.
Yes.
So why did you do an echo with the contrast study in this patient?
Ma'am, so an air embolism can be present in the bloodstream. So, but if it has to go to the brain, it has to trial via a shunt or through the pulmonary vasculature. To see the modality of the reach to the brain, we checked for a intracardiac shunt.
Okay.
It is easily absorbed into the vasculature,
Okay.
following which lipid peroxidation can cause oxygen liberation.
Where?
In the mitochondria, which leads to.
No, not cellularly, anatomically, gross anatomically. Is it happening in the bloodstream?
In the bloodstream.
Really? Okay, even if it is happening in the bloodstream, where in the bloodstream? How does hydrogen peroxide liberate oxygen?
Catalase activity.
Catalase activity. Okay.
Yeah.
And what does it break down into?
Water and O2.
Water and oxygen. Where is catalase present?
In the cells.
All cells. Most cells in the body have catalase. Okay. So where do you think the hydrogen peroxide is getting into contact with catalase first?
The cells.
Which cells?
The
mucosa of the gastrointestinal tract. It is also eroding into that. Cells are getting broken down. Catalase is coming outside. East contact is there.
Yes.
Right? So the oxygen is liberated in the gastrointestinal tract. There could be some absorption. It might be getting liberated inside around the tissues in the GI tract also. But most of the oxygen is getting. In fact, patients who ingest high concentration of hydrogen peroxide can have oxygen liberated in the stomach, causing gastric distension. Right? Yes. Okay. It is happening in the gastrointestinal. Okay. The veins, capillaries, or artery?
Probably in the veins.
Veins. Okay. So when it's happening in the veins, where do you expect the air embolism or the gas embolism to be?
It should go to the lungs.
Okay. So most causes of gas embolism because of hydrogen peroxide.
Hepatic and yes.
Which automatically leads to theory that most likely it is getting formed in.
Yes. So either it can go. If there's an extra. Yes. So if there's a shunt in the intracardiac or extra. Yes. He clinical features he didn't have. First, he didn't have. For usually in deep. Usually in deep sea divers and all, if dissolved and then released. Yes. Iatrogenic in when we put in an IGV or central line. Yes. Yes. The increased amount of oxygen, the amount of oxygen is high in this hydrogen peroxide when there is liberation of oxygen. So that is hmm. Yes. It will help, sir. So it will cause nitrogen washout, and it will break down. It will break down the air bubbles into smaller bubbles. Yes. Hmm. Yes. Hmm. 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 Yes. Yes. We don't have a CTR. Sorry. 6 hours after the insult. Yeah, we read the saline contrast after this. Yeah, after this. Hmm. Hmm. No central line support.